Today we have Dr. Ozanich with us, and he's going to talk about the Health Informatics program at NKU. He's the director, so he's going to share a presentation, and if you have any questions throughout it, you can put them in the chat, and then we'll make sure he gets to answer those.
Thank you, Avery, and hello, and thank you for inviting me and taking the time to listen to what we're going to talk about today. I think you're going to find it relatively easy. Now I've just got to figure out how to share screen again. And I put together a few slides, and please stop me at any time if you would like to ask a question or have some discussion. So health informatics, you probably have never heard about, and probably sounds like it's a pretty boring topic, but I thought I would just talk a little bit about why it is important, and also why close that down. Well, so why it's important and why you might be interested in a field. So, you're hearing a lot about healthcare, and so, obviously, why are you interested in perhaps a career in healthcare or studying about healthcare? Well, the options, there's a lot of options out there in terms of things you might want to consider doing during your life. And I've certainly changed jobs many times. I haven't been an academic my whole life, and I do encourage you to change jobs early and often to have an interesting life. But obviously in healthcare, you're making a contribution to society, and there's satisfying jobs and interesting work. You tend to be working with interesting people. There's really good growth opportunities. The population grows, so does healthcare by definition. It's a growing market, so there's a need for people to work in healthcare. There tends to be a lot of job security in healthcare because it requires some training and also experience, and as the market keeps expanding, there's significant job security. There's good pay for many jobs in healthcare. The average person who starts in health informatics makes $72,000 a year, so it's a really good paying field compared to others. And there's many different types of jobs. And I started that because, normally when you think about healthcare, you're thinking about direct patient care. You're thinking about people who touch patients, right? You're thinking about people who interact with patients. And one thing we're going to talk about today is how healthcare is changing, how it's really not going to be about going into an encounter with a provider, be a nurse or a doctor or a nurse practitioner, in four rooms, right? I mean, we're moving away from healthcare being delivered in a traditional clinical setting. And a lot of that is about health informatics. A lot of that is about how we're using data and how we're using technology. And there's so many different kind of jobs. So when I'm talking about today as a job, a different type of job in healthcare than perhaps you've considered or know about. Also, just feel free to interrupt me at any time, or if you got chat, Avery or Carolyn, please just jump in. So what is health informatics about? Well, health informatics ultimately is about the use of data and technology to promote better health care. And as you'll see in just a few slides, we're at a crisis point with healthcare in our country and really around the world. And we need to know how to provide better health care and have a healthier population. So really, when we're talking about health informatics and data and technology, we're talking a lot about care coordination. Nowadays, you see many different types of doctors. You see specialists, or you may see some individuals for telehealth purposes via the computer, or you may see a pediatrician or some type of specialized doctor. And what they need to do is they need to have data on the patients right now. And you probably haven't had this experience yet, but when you go in to see your provider, your doctor, or your nurse practitioner, or your advanced practice nurse, where you're basically filling out the same information over and over and over again, and they'll take a medical history, and you'll spend 5 minutes, or if you get old like me, you'll spend 10 minutes giving them a history of your care, because they may not have access to that information for when you've seen other providers. So one thing, and one of the most important things we do in health informatics, is we establish a patient record. And we're moving toward establishing what is basically a universal patient record. It's a very complicated process to do it because of all the technical standards and the various different types of computer systems involved in healthcare. And that's actually my specialty, the area of interoperability and standards between systems. But more importantly, we're trying to get the right information to the right place at the right time, so that better care is provided. We also want to provide improved access to care. Certainly with the new administration, that is their number one priority, looking at underserved populations. We'll talk a little bit about chronic diseases in a couple slides, but some socioeconomic status, mainly a lot of income, is a big predictor of your healthiness, and we'll talk about that in just a minute. So we want to have improved access to care. So that may be using your telephone to monitor your blood pressure. That may be using your smartphone to monitor your A1C if you're a diabetic, or your blood sugars. It may involve telehealth, where you're talking to a therapist, or an individual who's involved in behavioral health treatment. Particularly, if there's issues such as opioid use disorder, or issues like that. So it's a question of accessing care through technology that you might not otherwise have. A third example of why we use health informatics is to have the best and most current treatment. My wife is a medical oncologist, and there are so many new drugs for cancer. It's impossible for providers to stay current on them. It's really impossible. There's hundreds of new cancer drugs approved every few years. And how do you know if one's better than the other? How do you know what's appropriate for your patient? So what we have is we have something called clinical decision support systems. And those clinical decision support systems basically help providers get the most current treatment information. Or let's say that you've got cancer, and you have issues with reoccurrence. You may want to go in a clinical trial, right, of trying a new drug. Well, what we can do is we can use health informatics to basically bring that information to the provider, so that they can enroll a patient in that treatment. So that's called clinical decision support. Another area of health informatics is patient-centered care. Increasingly, when you go to a doctor, you have something called a patient portal. If you use the Epic system, it's called My Chart, and you can go in and you can see all of your records. You can keep track. You can communicate with your providers and the like. Patient-centered care is also giving the patient control in the decision making. We're really leaving the sort of very paternalistic system of a provider, a doctor deciding what's best for the patient. Now the patient really is involved in all of the decision making, and just receives recommendations from their providers. And I mentioned care outside of clinics like telehealth, and then mHealth and apps. And this can range from tracking the number of footsteps, the steps you take a day, to measuring your blood pressure real time, to used for fertility purposes. It's mHealth and apps are used for a lot of different use cases, and it's a really growing area. Health Kit, which is the Apple app for basically monitoring all your health needs, now connects directly with a lot of the providers' databases, so that you can have basically your lifetime health record on your cell phone. And of course, there are privacy issues about this and the like. And if you want to talk about privacy, we can talk about that. Right now, and I've got a number in here, I think there are 315,000 apps made for smartphones that are health related, which is pretty amazing statistic. Most of them maybe have a half dozen users, but that's the nature of apps. Any questions? So you get a sense of what health informatics is. We're basically using data and we're using technology, and we're helping providers get better information to take better care of patients. And we're trying to get the most current information to the providers at the point of care so they can make the best decisions and provide the best advice. We're empowering patients. We're also bringing in social determinants and behavioral health and basically true integrated care. And you need technology to be able to do that, to enable that. I want to take a minute to talk about what healthcare is, because this is really at the core of health informatics. In our country and in Western culture, or really as medicine is as it's defined, healthcare is the treatment of symptoms, right? In our model, it's the absence of disease. You go to a doctor with a complaint, and the doctor gives you or doesn't give you treatments, or maybe physical therapy or maybe medicine. And then if the symptom goes away, you're considered cured, right? So our really definition of healthcare is the absence of the indication for medical intervention, right? I mean, there's a standard joke in healthcare is, how do you define a healthy person? And basically that is somebody who hasn't been worked up, right? Somebody who hasn't had a complete physical, because everybody's got something wrong with them. But if we're looking at, sort of classic symptoms, be it fever, be it pain, or it could be a fatigue or any number of symptoms. I mean, basically we define you as a healthy person. But preventive care, and that's really what a lot of the current move and a lot of the activity in health informatics is about right now, is to be more proactive, to use predictive analytics. So, for example, we're going to be able to be more holistic, okay? So we can focus on physical, mental, emotional, and spiritual. And we're not just looking at the absence of symptoms. But by the same token, we can use technology to bring all of those factors together in terms of care. But also we can use technology to predict potential problems. We could use, personal genomics, to predict potential issues that an individual may have in the future. I mean, we also use predictive analytics to determine what the best type of medicine to give a person is. And that's all through the use of databases. But so I just want to give you the idea that really where we're going is toward population health. We really want to have a healthy population. We just don't want to be in the business of treating diseases. Any comments? I don't know if you know this number, but it's a staggering number. In the United States in 2019, we spent $10,966 on each person in healthcare. So if you're a family of four, right, that means that there was almost $44,000 spent on average for your family. Now, obviously, it's not. It's more in the tails of the distribution. I mean, we know that 5% of the population accounts for 80% of the healthcare expense, something like that. But I mean, the fact is, we can't afford to spend $11,000 a year per person on healthcare. And that's really what gave the whole impetus to health informatics, right? The government sat back and said, we have to do a better job in terms of providing health care because it's better for our citizens. But more importantly, as a government, we can't afford to spend so much money on healthcare. And you could see, I mean, these numbers, I'm sorry, they're only from 2018, but they're the most recent numbers I was able to get. The United States in 2018 was spending $10,200 per person. The average OECD country, which is mainly Western Europe and Japan, Canada and Australia, was spending $4,000. You could see in the UK, they're spending $4,200 a year on healthcare, where in the US, we're spending, more than twice that. We can't afford that as a country. We have all these bills, all the spending coming out now relative to COVID relief, and now the infrastructure bill that was announced this morning. Ultimately, you just can't print money, right? You have to get things under control. So as far as GDP, and this is an old number, but it only comes out every 10 years, so I got the 2020 numbers. Right now, we're spending almost 19% of our GDP. So if you think of the gross domestic product, that's everything that's produced in the United States today, and essentially 20% of that is going into healthcare. Now, that's one reason why it's a good career choice, but also just think if we were able to get that down to 10%, that's substantial money that could be spent fighting poverty. That's substantial money that can be spent on infrastructure. That's substantial money that can be spent elsewhere, or reduce taxes so people can keep more money. So we're just spending way too much on healthcare today. That's another reason why we're looking at health informatics. This is an older slide, but I just wanted to pull it up because I think it's really important. Right now, chronic diseases are a real problem. Diabetes in particular is really a chronic problem. We've got I think 12% of the population is diabetic. For hospital readmissions, 1 out of 5 are readmitted if you're on Medicare. We just have a lot of cost problems in terms of healthcare. Chronic conditions cost 85% of all our health expenses. Mainly the big expense is diabetes. And then you go to cancer is a big expense. Obviously, that's considered a chronic condition. It is a chronic condition. You can also look at congestive heart failure, kidney, all these sort of chronic conditions that cost a lot of money. So that's why we're saying, hey, what if we were more engaged in predicting when people have these diseases? What if we can do this quite easily with artificial intelligence and machine learning? We can predict whether somebody is going to get diabetes or some other chronic disease, and what if we're able to intervene and reduce those costs? I mean, it's better for the patient. It's also better for everybody. So just also want to mention some amazing statistics. Right now, 1 out of 3 children born in the last decade is going to develop diabetes. For Latino children, it's 1 out of every 2. If you're looking at quality of life, 1/4 of the people with chronic diseases have some sort of issue with mobility or personal care, and it's just something we have to deal with, and so it's not just about getting people to live longer, but it's about getting people to live better. Population's aging. It's quite interesting in that in the United States, if you're 90 years old, we're going to spend an average of $45,000 a year on you. You could see in other countries, I'm often accused when I use this slide of suggesting that the European countries just let old people die, but that may be the case. I don't know, but it's an interesting statistic, right? In terms of the heroic actions we take with people as they get older. Our default in the United States is you go on life support, right? Not to necessarily criticize that, but it's a interesting. Another factor I want to talk about, and this is about, personal characteristics. I bet you know about health informatics is all about this, but it really is, because we're dealing with social determinants. Right now, your zip code is a better predictor of your health than your genetic code. You may have seen that in other presentations, but your longevity and your likelihood of getting a disease is predicted better by your zip code than by your genetic code at this point. And your health and well-being, we know that it's roughly 30% genetics, 40% individual behavior, 20% socioeconomic factors, and 10% healthcare. So much of health informatics right now is focused on, actually, we're involved in this 10% of healthcare, and that's what everybody thinks we do in health informatics, but it's really a small piece of it. We're involved in the genetics piece, in doing the biogenomics and doing the predictive analytics with genetics, but we're also involved in trying to bring social determinants and coordinate care by bringing data together by different types of providers. One of the challenges you have with social determinants is that the data tend to be what we call unstructured data. So think of it as if a patient is seeing a therapist, right? What does that therapist do? That therapist writes notes. That's unstructured data. Where if you go to see a doctor, a medical doctor, what's happening is basically you're capturing a medical data. Blood pressure, that's a number, right? Blood sugar, that's a number. Height, weight, demographics, age, those are all numbers. Those are called structured data. So one of the biggest challenges we have in health informatics today is trying to combine structured data and unstructured data so that they can be used together to give integrated care to a patient. And there's a lot of interesting things going on there, like natural language processing, where those notes are being read and basically coded for key terms. The problem you have is there's no standardized way that data are written down by any type of provider anytime you have notes. So anyhow, I'm just sort of giving you the big picture. So healthcare in the US, health informatics is at the forefront. We've had $38 billion spent in the last 10 years to that's taxpayer dollars. And that has probably been, matched by 10 times as much by the actual healthcare systems, probably a 10-to-1 ratio, something like that, depending on the type of provider. In terms of trying to change how we deliver healthcare. And health informatics is at the forefront of this, right? We're trying to bring data so that we can change healthcare from just treating symptoms to giving more holistic care and a better picture of a patient. We also have to change how we pay for healthcare, because we can't keep paying so much money for healthcare. We have to change where and how healthcare is delivered. We have to use computers. We have to use technology. We have to use smartphones. We have to meet the patients where they are so that we can have patient-centered care. And then we absolutely have to integrate physical and behavioral health. So that's essentially what we do in health informatics, and that's why there's so many jobs in it, because it's really a relatively important field. So our goal in health informatics really is to have better health outcomes, a healthier population. If we could do anything to use technology and data to bring down chronic diseases like diabetes, congestive heart failure, kidney failure, particularly those lifestyle type diseases, smoking, lung cancer. If we can do anything to have better health outcomes, our cost of care is going to go down and people are going to have improved health. So that's really sort of what we're focused on, and this requires a whole new individual approach and something that's called population health. And to have that, we have to have an interoperable health system. Interoperable just means we have to be able to take data from one piece of the health system to the other piece of the health system. So do we have any questions? Have I lost anybody yet?
All right, you all, you know the drill. You can ask questions in the chat. You can unmute yourself. I know it's been a lot of information. It's been really exciting.
I have a lot more stuff to talk about too, but I thought I'd pause here. It's an interesting field.
Yeah.
Avery's going to change her decision on what she's going to do for her master's degree after this.
I might.
All right. Well, we haven't had any questions yet.
Okay, I'll talk about this then.
Okay.
Okay. I'll give some examples of what we do in health informatics, right? So the first is the area of electronic health records, right? Now, when you go to see a provider, you may notice that the provider, you may be too young to remember this, but it used to be a provider would sit and listen and talk to you. But now when you go to see a provider, particularly a primary care physician or a primary care nurse, they're basically sitting at the computer screen typing up, right? Now, the reason that's happening is, first off, they only have 15 minutes to see you. And so they don't have time, or nor are they paid to capture those notes. I can say I know this from experience since I'm married to a physician, right? My wife's primary care provider was writing patient notes this Sunday night, right? From everybody he had seen last week. And I guarantee that you're not paid for that, right? And that's family time, there's a huge opportunity cost involved with it. It's just not the money, but it's taking care of it. So what the providers are doing is they're actually putting in text and numbers. Well, the numbers are captured automatically into an electronic health record. And the most common type of EHR or electronic health record is manufactured by a company called Epic. So if you go to St. Elizabeth, if you go to Christ, if you go to Mercy, if you go to UC, or if you go to Tri-Health, or if you go to really any of the other major health systems in the Commonwealth, they all use Epic now. And Epic has really, really done a very good job in allowing those different types of providers to share data. So you can go to see a provider at Christ, and they can capture data that you had from St. Elizabeth. Or I had healthcare up at Ohio State University a few years ago, and I go to St. Elizabeth. Well, they were able actually to integrate my St. Elizabeth chart with my chart at Ohio State. So there's one unified health record. Now, what was good about that is I didn't have to repeat tests, right? So if they could see the tests you've taken at other hospitals, then that saves a heck of a lot of money. Also, if I'm happier, I don't have to go sit in some uncomfortable chair waiting for tests and the like. And also it's just better care. It's more timely care, and the doctors can coordinate care. So the government, as I said, has spent $38 billion since 2012. And I'm happy to say I have been a recipient of a lot of grants in those $38 billion and a lot of consulting work in those $38 billion. So I'm not exactly impartial in it, but we're implementing EHRs. There's still issues, but the idea though is that we have a computer entry of the patient data. Once we have that data in a database, we can do really great things with it. Okay, we can start to do all those other things we talked about. So the type of career for electronic health records, and initially we've had a lot of students who graduated and worked directly with the EHRs, is you're implementing electronic health records, either working for a company like Epic or Cerner or Greenway, one of the larger vendors of EHRs, and helping install them, or helping at the local hospital install them. And then once they're installed, they need to be maintained, and you need to train people how to use them. So you need to be subject matter experts on how to use it and pull the data out. But anyway, EHRs are a very vital part, and think of it as the way that the data are captured. I'll tell you an interesting statistic. A lot of doctors now are basically evaluated and paid by Medicare based upon what patients think of them. If you've been to a provider, they'll give you a survey. What do you think of the doctor, right? And the providers, I've seen a lot of the research on this. About 30% of the patients say the doctor's not treating me, they're looking at the computer, right? And they ding the provider and they make complaints about the provider. And, but then actually the majority of patients say, hey, this is the first time I think the doctor's really listening to me because I can see that they're typing in what I'm saying. So it's, in that health comm side, it's kind of an interesting encounter in that clinical setting. So at any rate, so that's electronic health records. And you can think about them anytime you go in to see your provider.
We do have one question if you want to.
Okay, fire away.
This field seems to touch on a number of disciplines. Can different degrees lead to work in this field?
Yes. Also, if you're interested in taking a master's degree, actually any degree you have is fine and you can specialize. But yeah, if you have a passion and an interest, there's a path. I was talking to, I was up at Christ Hospital with a family member, and I was talking to the person who does all of the EHR training there, and she actually has a degree in social work. So, but she had a passion for it. So it really can, it's a question of doing what you want. So any degree. I mean, what I suggest is finding something you're really fascinated about. We have students come through who say, hey, I want to start a company and I want to develop an app for healthcare. And, that's one path. A lot of students, and I think too many students, in my opinion, just want to get a job at a hospital and they think they got a career path for life. And I say, well, you're going to be stuck in a cubicle for 30 years. Think bigger than that. It drives me crazy when students don't think big enough, take risk. The cubicles are always there. But anyway, enough of my opinions. So what about clinical decision support? So think about that. Think about if you're a cancer patient, right? And you failed the standard treatment and it's looking very terrible, right? Well, you're desperate. Well, your doctor now can basically go in to a variety of websites and they can match your genomic profile with your best treatments on clinical trials. And it's fascinating. It's wonderful. One of our graduates who actually teaches for us adjunct, he works in Chicago now for the ASCO, the American Society of Clinical Oncologists, and he runs their clinical decision support initiative, which is basically taking the big database that they have as a nonprofit organization of all of the clinical trials that are available out there for cancer patients, and they make it available and integrated into an Epic or a Cerner into the EHR. So a provider then can write a query. And another key thing about personalized medicine, and this cuts both ways, and this is where ethics and privacy get into it. If you can take a genetic test right now and know the likelihood that you're going to have Alzheimer's disease in 30 years, or if you can take a genetic test right now, and they take your family history, right? What your grandmother, your grandfather, your mother, your father, your brothers and your sisters, and that's normally what they take. And what they try to do is from the family history make some prediction about your care, right? My brother-in-law's got a condition that his father had, right? And it's highly predictable. Well, we're getting very close to the point where we're going to be able to do that with genomics. Okay. And that's another area of health informatics. Now that may not be for everybody on this call. That's really the geeky stuff, right? That's writing the SQL queries. That's really getting into the databases, but it's still a very important piece, right? And you don't have to know how to do that. In our program, you do take a basic class in programming, but you don't, it's the students who really want to specialize in that. So you learn about most current treatment. Most important is the alerts. So let's say they make a mistake with the prescribing. gosh, what's the number? To err is human. There's a classic article, a classic study that was published about 15 years ago about the number of people who are killed in hospitals and by doctors, right? I mean, it's even like giving the wrong medicine because of an interaction, like not knowing perhaps you had a reaction to penicillin, or it may be possibly an alert because of the amount they prescribed, or an interaction between two drugs, right? Like you're not supposed to have antibiotics and some type of vitamins, and so most importantly, it's if you put in the wrong number, you know, and there used to be this huge problem. If you heard about, doctors' handwritings, right? They used to write a script and you used to give it to your pharmacist. I don't know if anybody's old enough to remember that, but the doctor would write a script, you'd give it to your pharmacist, and the pharmacist would look at it and try to read what was said. I mean, I've got some great actually videos on that of what it said. Now this is all done electronically, right, through e-prescribing. And 96% of all scripts in the United States today are electronic. So the docs can still phone them in, but really it's an issue of all of that is done electronically now. So we have a lot fewer errors. And also there's CDS at the pharmacy, because you may be going to two different doctors and they may pop up and say, hey, wait a second, another doctor is giving a drug that's going to interact with this. So that's another one. Another type of error you may not consider an error is like opioid prescriptions. We have something now called the PDMP, Prescription Drug Monitoring Program, in Casper, which is called Casper in Kentucky, which actually looks at the amount of opioids that are prescribed for an individual to try to reduce the amount of addiction that occurs in doctor shopping and illicit use. So there's a lot of ways we use CDS, right? It can also act as an extender. The provider can look something up immediately on the computer, or the computer actually can come up and say, do you want to know about clinical trials for this patient, right? And you just click on it. So you can use artificial intelligence, you can use machine learning. This is like one of the areas I spend a lot of time talking about in my classes, which is artificial intelligence is really hyped, okay? All it is linear algorithms, if, then, or buts, right? It is not really computer learning. It's just taking the, if allergic to penicillin, don't prescribe, and then it'll tell what drugs, okay? That is artificial intelligence. Machine learning, on the other hand, is actually taking the data and having the machine iterate and look for patterns, right? And take the personalized medicine and look for patterns and come back with a better way to treat the patient. So AI is really just linear. It's taking what we already know, right? It's like in a cockpit. It'll tell a pilot how to fly, right? But it's all pre-programmed. Machine learning is actually getting to, the very futuristic area where you have the computer being smarter than the provider. The computer able to compile all of this information and come up with a suggested treatment. I think we're about 10 years away from that. And there's going to be a time where a doctor is going to have to justify her or his treatment if it varies from what the computer tells them. Okay, that's going to happen. And that's all health informatics too. As you're going to talk about how it all works. I mean, this is, if I had any geeky questions, I was going to talk about how clinical decision support works, how you have data in, and you have the data here is the knowledge, and then you have either a linear, I'm pointing, it doesn't do any good, linear algorithms or machine learning algorithms that'll help you get to various outputs. But that's kind of, it's an interesting area, and we have a lot of students interested in that area. Health is the area I talk about. It's to me, mobile health is any place outside the four walls of a clinic. increasingly, to me, it's telehealth. I have a broad definition of it, but it's getting to the point, and, it drives some providers crazy. How can you diagnose a patient without touching them, right? I mean, it's just so ingrained into healthcare. But I mean, we learned a lot during COVID, right, about telehealth. We also learned a lot about the limitations of telehealth. Right now, telehealth reduces costs mainly because providers aren't paid the same amount of money. Until COVID, in almost every case, if you saw a patient, you were not reimbursed. I don't want to always take the physician side on costs, but I mean, there's a cost of time, right? I mean, providers, I mean, it's not, a 24/7 job. They have lives too, right? And there's burnout. Right now, if you send your doctor or nurse an email and they spend time to reply to it, they are not paid for that time that they're replying to it. And also that email could turn up in a court case if it's not written perfectly, if there's any misinformation. So it's really, I mean, the liability issues are huge. The lawyers always make out, and it's an issue. So anyway, I'll stop with my lecture, my worldview. Extending the health of reach care, we have efficiency, speed, and location. Engaging patients and improving convenience. Wearables, I don't know if any of you have used the wearables. I don't. Simply because I don't think they're valid, but it counts how many steps, or you can look at your BP. But you can see a time where, I mean, this was kind of scary when we look at all the other sort of government activities going on potentially for surveillance, right? But where you have a chip, and it's possible to monitor all of your physical activities as well as your geolocation, right? In the People's Republic of China, they have social scores, and you have to have so many steps. You have to have a BMI of a certain, a body fat content of a certain level in order to get an acceptable social score, right? And all of that is a way to have a healthier population. It's also a way to control. And if you don't have an adequate social score, you could lose your ability to travel internationally. You can even lose your train passes to travel outside your regions. So, I mean, there's a lot of scary stuff that can happen here too, with all of this monitoring and all of the collection of data. And then there's the telehealth, but ultimately, we want to reduce costs. What we want to do is empower the patients. I mean, we want to, and I wish more people would do it. I wish more people wouldn't use Google, because Google monitors everything you do, or wouldn't use Facebook, but people do, and so there's huge privacy issues, particularly if you're talking about your health. If you send an email about your health, you could try to send a Gmail of something about health, and you'll start to see ads pop up about that health, unless it's about suicide or mental health. So there's all that targeted advertising out there. But anyway, there's now more than 320,000 health apps out there a day, 200 added a day. Nobody's making any money on it. But we think that younger people are going to be more willing to be engaged with their health. So I think that's mainly, value-based care. Traditionally, the way we paid for healthcare in the United States is you would go in to see a provider. The provider would write down a diagnostic code for what you had and the characteristics of that interaction, and then also anything that any shots you received or any other activities that occurred, and then there's a code for all of those. Then they send to an insurance company, and then the doctor or nurse practitioner, whoever it is, gets paid, right? So that's called fee for service. And that's one of the reasons why we have such very high costs. There was no incentive for providers to reduce the encounters, because the more patients you saw, the more money you made. And there was no reimbursement for quality. So what we're doing now is we're moving to quality-based outcome, and this is called value-based care. And the whole idea of value-based care is that we pay providers based upon the care they provide and not the volume of patients they see. So, for example, if you see a diabetes patient, if you get their A1C below 7.0, if you have 70% of your diabetes population with an A1C below 7.0, you're going to get paid more than a provider who does not. Now, there are obvious issues with that because some patients in some regions are much more likely to be adherent than other patients. If you're at a large urban hospital or university hospital, there's a documentation that you're much less likely to have patients stay with your recommendations, adhere to your recommendations, than in a suburban hospital. So it becomes, you have to risk adjust populations, and we're still figuring out how to risk adjust populations, but that's part of informatics too. So I think that's it. That's sort of a big picture of informatics. You can see we do a lot of things.
All right, we do have a question. Avery, do you want to take that?
Sure, yeah. It says, how commonly are EHR students studying ethics, since some of the information gathered could be questionable and others don't think twice about it?
Oh, well, everybody is trained. Everybody has a class in ethics. Everybody should know what's right and what's wrong. But let me just say there's an organizational culture. Depending upon where you work, who your supervisor is, and who you're trained by, right? You may have somebody who says, all that stuff's academic, forget about it, right? But I mean, privacy could not be more important, but and ethics too. But I'll tell you what drives privacy more than anything else. It's the worry about lawsuits. And that's access to information. Ethics is an issue. Electronic health records are really great because everybody thinks they're less secure, but they're really more secure because you have an audit of every single person who saw the record. So they way back in the 1990s, Bill Clinton had heart surgery at Columbia Presbyterian up on the west side of Manhattan, and they did an analysis of fingerprints of people who touched his paper chart, and there were at least 28 people where they identified at a fingerprint who should not have touched that chart who did touch that chart, right? Now those people, if you look at a celebrity's chart, and this happens in Hollywood all the time, you get fired. I mean, they know who you are, right? You have something called break the glass. So you can put in, normally it's double authentication. You'll have an ID and typically a fingerprint or a code sent to your cell phone to allow you into an EHR. And then what you do is you can put in the patient's, birth date, social address, however you use it with the master patient index. If you are not allowed to have access to that patient, there's this big thing that says you're not allowed access, right? Now, if you're a provider in an emergency room, you could do something called break the glass. That's like if you know how when you look at a fire alarm in a hallway and you break the glass to pull it, right? It's an extra step you have to take in order to do that. And then they know who you are and you have to justify why you did it. So there's far more privacy today than there ever was. Ransomware is a big issue. 97% of all healthcare breaches for privacy don't occur because of the electronic health record. They occur through phishing attacks with email of employees. So an employee will open an email link and basically, a program will come in and be able to it's typically ransomware these days. So I don't know if that answers the questions. Ethics is huge. There's more people we need more people teaching that, incidentally. We need more people studying that. This whole area of electronic health records and digitization and ethics, it's a whole brand new frontier. It's a whole brand new frontier. Privacy. I don't know if you know this, but once you're 12 years old, from ages 12 to 18 or 11 to 18, a parent can't see the record of an adolescent because of privacy. So one of the big challenges we have had is, how do you give somebody 12 to 18, depending on state law, access to their electronic health record, but not allow the parent access? Because it's an unequal power relationship, right? The parent can extort the password, but what if the adolescent has confidential conversations with the provider about parental abuse or sexual activity or anything like that, right? So what we do actually is we just don't provide electronic health records. That's the easiest way out. But there's a lot of ethical issues. There's a lot of privacy issues and the like. And we didn't even talk about third-party apps. Microsoft and Google want to take control of your health record and integrate that. Facebook's interested in it too. So there's all sorts of privacy issues. I mean, if you really think about this stuff, you stay up all night worrying about it. Other questions?
Nothing so far, but we'll give everyone just a minute to think about any questions they have. If you have anything that you thought you didn't include in your presentation, but you'd like to talk about, maybe the health informatics program at NKU.
Okay.
In the meantime, I'll drop in all of our survey stuff.
Okay. Yeah, we do have a bachelor's degree and we do have a master's degree. I didn't treat this as an advertisement. I probably should have, but that's not my style. I figure I believe in attraction rather than sales. And I think it's such a compelling field. If people learn about it, they'll be most interested. So we do have a bachelor's, and then we have a minor for undergraduates, and then we have a master's. So I could have done that.
And I like to ask, what opportunities are there for like undergraduate research or internships? Or
Yeah, COVID's made it very difficult. I've been running the undergraduate internships this year, and also the undergraduate capstone. So there is an undergraduate capstone requirement, which is experiential experience. The graduate level is all about experiential, of course, but we'll talk undergrad here. Yeah, in your senior year, you basically spend at least one semester. I've not been able to place students on site for a year now because of COVID. It's been a real challenge.
Yeah. What has been like some of the most interesting places people have been placed?
Oh, I think, gosh, there's so many interesting things. Public health during COVID. I had a student actually work on creating the database for the Fayette County tracking inoculations for COVID. They would have had a huge mess without the database the student assisted with. But, it was a very important extender, if you will, I had another student, actually, this was a graduate student at Moffitt Cancer Center in Tampa, create a database for that tracks all of their clinical trials and all of the patients on their clinical trials and the outcomes for those patients. It was all being done on a provider by provider basis. So they had a better understanding of what they're doing with clinical trials. I had a student work on at children's hospitals, probably where we get most of our graduate students. And we have physicians come through also. So it's an interesting graduate school. We have an interesting mix of students. But we had a lot of projects at children's. Everything from sort of the social determinant piece of intake, how to use data better when you're bringing a family in for care. That was an interesting project. To geeky stuff like imaging studies for cardiology, better organizing the imaging studies for cardiology, the cardiology department. So we do a wide range of things. Like I said, the unstructured stuff's really interesting. And Carolyn, as you know, we're doing a ton of stuff in opioids right now, substance use disorder.
Yeah.
So now I've had a couple of students who really helped a great deal this past semester with identifying codes. We're about to get a whole bunch of data on 1.3 million patients. We needed to know what codes we're going to be looking at for substance use disorder, and that includes social determinants. I could just talk forever about social determinants. They're such an interesting data problem. You know, if we can figure out how to deal with them and integrate them, care will be so much better.
Absolutely. Well, we haven't had any other questions come in, but you do have a thank you in the comments.
Okay.
So thank you to you for your presentation, and then thank you to everyone in our audience for attending and asking really thoughtful questions.
My pleasure, and I'll be happy. Send me an email. I'll be happy to send you information about the programs.
Awesome. And then next week, we do have our Meet the Experts presentation with radiology. So if any of you are interested in radiology, that should be a really fun presentation.
It's a lot about informatics now.
Yes, absolutely.
They're reading a lot of scans and images with computers. It's a fascinating field.
Very cool.
Yeah.
All right. Well, thank you to everyone. Have a great day.
Bye-bye.
Thank you.
Bye.